the response to therapy that preceded the consideration for maintenance. Now, so just to reiterate that, so therapy after complete remission is called maintenance, and therapy in the setting of a response is often called consolidation. So then we went to make this even more confusing. We introduced a third term. So we got maintenance, we got consolidation, and now we got this term called switch maintenance. So this was actually popularized by some of our trials that were focused in patients who had recurrent disease and were given chemotherapy. And then based on their best response over here, whether it was their second or third line of chemotherapy, we switched the drugs and gave them something completely different. And that got termed as switch maintenance. So you'll hear the terms maintenance, consolidation, and switch maintenance kind of used interchangeably, but they do represent slightly different things. But I wanted you to see the graphics, so you understand when we talk about these additional therapies, where they kind of fit in the sequence of therapy. So it's kind of almost like, what? What did you say? And I get this a lot from patients in the clinic too. So I thought what I'd do is spend a little time and kind of walk through this and try to provide some clarity as to what we're doing now, what we've evaluated in the past, and what are the kind of the goals and endpoints of using this kind of therapy for our patients. Okay, so as I mentioned kind of in the beginning, that we know that although CAT scans and CA-125s can normalize in response to treatment, there's a very high proportion of patients that if we actually look by surgery, that we're able to find very small nodules, or what we call subclinical disease in the abdominal cavity. And so, the chemotherapy that we are using is quite active and has a very high rate of responses. So you can see that these complete responses and partial responses, which are responses that are not complete but definitely show decrease in tumor volume, happen in about 75% of patients. And it's interesting that for patients who've never seen chemotherapy before, this 75% response rate happens here and it happens here. So it can happen not only after primary chemotherapy but also in recurrence. And so, there's very high rates of at least having a clinical remission, but we know that if we operate to evaluate, we find that it's actually, there is a fair amount of subclinical disease. And we know from just our clinical experience that if we don't do anything right here, that over time, tumors will start to reappear because they'll start to grow. And so the concept of this maintenance is a way to keep that from happening. And while that makes a lot of logical sense on the surface, it has been harder to achieve or to validate than you might imagine. And I think one way to think about this is that if you kind of treat this disease with a chemotherapy regimen or so, that has incomplete remission, so that the tumor has gone down but hasn't gone away, those cells might be resistant to whatever it is we might want to use in maintenance. And they may be, although they may be slightly resistant to the chemotherapy that was already given, they can oftentimes be resistant to other drugs. So it's almost like they develop this global resistance pattern, so that if we introduce a new therapy, it would be as if we gave no therapy at all. And so, so it's been very important for us to evaluate in this box, the efficacy of these drugs against either other drugs that we know have that might be efficacious, or even just observation. And so, as many of you may know now, because with the PARP inhibitors, that maintenance trials that showed their merit in patients with recurrent disease were given against placebo, and we'll very soon find or hear about new treatment in this particular first box, maintenance, that also was given against a placebo or no active therapy. So, I think that when we look at how we can declare whether or not treatment is a success or not, there's kind of intermediate endpoints that we can use. So one of the easiest endpoints, if you think about it, in a situation where you have a group of women who do not have any evidence of disease by their CAT scans or their PET scans, and they're given therapy versus no therapy, the only kind of next thing that's going to happen is going to be the appearance of recurrent tumor. So the time from the completion of treatment or from the initiation or in maintenance trials, from the time of completion of the frontline therapy, so the time of randomization to the time of recurrence, is called progression-free survival. And you'll see that term used pretty ubiquitously. We sometimes abbreviate it as PFS, so progression-free survival. So I'll go back to this slide. So from this example here, if we were to evaluate a trial that's looking at a maintenance therapy versus, let's say, placebo, then we would measure from this point in time here, this bar, till this bar over here, which is progression, and that would be considered a progression-free survival. Same thing here. If the new therapy is introduced after chemotherapy 2 here, then it would measure the distance between there and when it came back for therapy in number 3. So, and that's what's called progression-free survival. Now, one thing I'll mention is that we do have somewhat of concern about treating patients who might already be cured with something that they don't need. So what I mean by that is, I keep trying to go forward here. What I mean by that is that when patients present, let's say here, after their first chemotherapy, and we don't know whether or not that tumor is ever going to come back. But if we give everybody maintenance therapy here, then we're treating a proportion of patients, and it could be significant, maybe 30–40% of patients who never needed it. So we have to be very cautious about how long we extend that therapy when patients have a recurrence. And so for many of these trials, there's a fixed number of courses. So if any of you are wondering, well, how long do they treat me? When it's the first recurrence and you're in this maintenance box, almost every trial that we run has an upper limit of number of cycles of treatment. And so, for instance, in the most recent trial with Olaparib, which I'll talk about a little bit later, the total exposure was about 24 months of treatment. Now, in the recurrent setting, the likelihood of those cures is lower, and so it's been considered acceptable to continue to treat until the drugs don't work anymore. And so most of our trials in the recurrent setting are more open-ended. And so many of you may actually know people who've been on a maintenance drug in the recurrent setting for months or years even, and that definitely does happen. So the use of this maintenance regimen is different when we think about it from the context of frontline treatment versus recurrence treatment. Okay, so as I said, for more than 2, maybe 3 decades, we have been looking for the right thing to stick in that first box, that first maintenance box. And I just have a list here of the different types of agents and drugs, strategies that have been done over that time period, from everything from prolonged initial treatment. So in other words, we did a series of randomized trials where women got 12 months of chemotherapy versus 6 months, or 8 months of chemotherapy versus 4 months, or 6 versus 12 months. We did a lot of double exposure types of experiments, and we found that was really didn't add much to the benefit in terms of overall survivorship. We looked at the use of short duration non-cross-resistant chemotherapy. So this was a kind of a switch maintenance chemotherapy kind of strategy. We looked at high dose bone marrow transplant chemotherapy. Lots of people think that, well, if I got a standard dose of chemotherapy, then maybe more dose of chemotherapy would be even better. I oftentimes hear from patients, the chemotherapy didn't make me sick. I wonder if it's not working. We hear that a lot. So, but we looked at that with formal bone marrow transplant in this setting. We looked at intraperitoneal chemotherapy. We looked at interferon, which is an immunotherapy. We looked at vaccines and antibodies against CA125. We looked at other biological agents that target different factors of the tumor microenvironment, like bevacizumab, a drug that you may know as Avastin. We looked at paclitaxel given in 2 special formulations for 6 months or a year, and we looked at growth factors such as erlotinib, which are drugs that actually do work in other disease types, but they, when we looked at them in ovarian cancer, oops, oh darn, didn't show up here, but we didn't show any benefit. So all of these, none of these therapies actually turned out to be beneficial in terms of overall survival. So, so it was somewhat disappointing, but it's not, you know, after having experienced all this work, it was not surprising that our standard of care after women finished frontline chemotherapy was observation, because all of these trials, you know, did not seem to extend the life of women when they got it. So we kind of like parked it there. And I wanted to show you at least one example of what one of these trials was. This is a drug trial we called the OVAR-16 or AGO-OVAR-16 trial. This was a randomized phase 3 trial. So that means that it was flip of a coin. Patients you can see here had first-line treatment and chemo. And then if they did not have any progression of disease and they had a relatively small tumor volume, they were randomized to drug versus no drug, and then for 2 years, and then they were observed. So this is just as I mentioned before. This drug called pazopanib, the drug they gave, actually targets a number of factors that are considered important targets for growth of tumors. So VEGFR, angiogenesis, these PDGFR are part of the supporting cells that are in the microenvironment. c-KIT is a growth factor, as is this fibroblast growth factor. So this is a drug that has a lot of targets. And was given in a blinded way to women with frontline therapy. And this is just a kind of a schema, a table of what kind of the characteristics of the patients who went on to treatment. And you can see that that most of these patients got very much the standard type of chemotherapy, and most of them have had a very good response. So you can see here that 86 and 84% of women, 85 overall, had a complete remission of their tumor before they went on to treatment. And and they were enrolled within about 2 months. So I know most people don't know what these curves mean. I see them all the time, and they even show up in all kinds of magazines, but I want to describe just briefly what this is. So what we have here on the bottom are the months in time from the time of randomization. So this is 6 months, 12 months, 18 months, etc. And this y-axis that goes from 0 to 1 is the proportion of patients who have who would be considered, in this example, progression-free, so no evidence of the tumor coming back. And you can see then at time 0, when everybody goes on the study, there's 100% progression-free survival. But as time goes on, you can see that progression events start to happen, and these two curves then start to split. So the blue line represents those patients that are on the pazopanib, and the red line are the ones that were on placebo. And you can see that over time, as you would expect, as tumors start to come back, the curves kind of go down in a kind of a banana shape. The difference between these curves, which is what we use as the measure of the treatment efficacy, is this like the area between these two, which I have brown in that brown fabric color. And that would represent the overall benefit. And we represent that brown number as what's called a hazard ratio. So with this, if you can look at this as 0.76, that means that there's about a 24% reduction in the risk for progression at every single point on this curve. So over time, that there seems to be this reduction by about 25%, and that seems pretty good. And so you'll see here doctors talk about that. So they'll talk about the hazard ratios, or they'll talk about the difference at the median, which is the 50% line. And that's, if you draw this line over here, it would be the difference between this point in time, which is about 12 months, over to this point in time, which is about 18 months. And that's why they got that 5.6. So you hear those kinds of terms thrown around. So when we say something is better than something else, we're using this kind of statistics and these kind of optics to declare that. So, but this was the kind of the bummer. We saw that you know, there was no difference in overall survival. So you can see these curves are kind of overlapping each other. In fact, the placebo curve out here at the tail of these curves is actually a little bit better than the drug. And when we looked at that in terms of toxicity, we found that the toxicity such as high blood pressure, low white count, liver toxicity, diarrhea and fatigue, and other bone marrow problems were all substantially higher, significantly higher than was the placebo. So it raised a question that if we had a compound that delayed the time to the first progression but did not make patients live longer and was more toxic, was it really an advance? And so I think one of the findings we saw in this trial also that was unexpected was that among the Asian patients, we actually saw that the drug had a higher mortality rate. So it was more toxic in a way that was actually quite negative. So this drug is, because many of you may not have heard about this drug, but it really hasn't developed any further because of this study, which looked positive initially, but that as we looked into it deeper, we realized that it wasn't, and so it didn't make it into our treatment regimen. So, as I mentioned, we've tried all these things. Now, there's a couple of examples here that have little asterisks on them, and I want to talk about one of them. That's bevacizumab, because that drug is now approved in the Frontline. So this is a kind of a complicated slide, but I'll walk you through it here. But it represents one of two trials that were looking at this new drug called bevacizumab, which was being used in patients who have, or which is a drug that actually targets the blood vessels that tumors like to get so they can grow bigger. So this was a 3-arm trial in patients who were newly diagnosed with ovarian cancer. And you can see it's a large trial, nearly 2,000 patients. So the standard of care arm was carbotaxol plus placebo. There was an arm that had carbotaxol plus bevacizumab or Avastin, followed by placebo and maintenance. And then there was the experimental third arm, which was Taxol Carbo Avastin, followed by Avastin for a total of 22 cycles or 15 months. So 3 arms. And so the trial was set up to examine the benefit of the bevacizumab in maintenance. The second trial that was done overseas, we call ICON 7, very similar design, but only 2 arms. You can see 1,500 patients. Taxol Carbo, bevacizumab. And the bevacizumab, you'll notice, is a little lower dose and given for a little less time. But overall, they were both kind of trying to prove the benefit of this drug. And so these are the curves. Again, remember how I explained the time on the bottom and the percent of patients that were progression-free on the axis. And you can see that the patients who got the Taxol Carbo plus the Avastin, actually up on the start curve here and on the red curve over here, basically showed a big benefit. And the hazard ratio for both these trials are very much favorable and are below 1, which would represent a benefit. But neither of these trials actually demonstrated a benefit in overall survival. So the question is, well, then how did it become? If the other trial just showed you didn't do it, how come this trial did? And it's actually a pretty good question. Actually, the trials were done almost about 6-7 years ago, and they've been in the public domain for that long. And there was actually not a lot of urgency to get these drugs into the frontline setting until we realized something that we hadn't in the past, and that's that even a progression-free survival can be important if it can be if the drug can be administered with low toxicity. And by the time the FDA received the documentation of this drug in the frontline setting, there have been tens of thousands of patients treated with the drug. And so the safety database was quite large. When they reviewed that and they reviewed the potential subgroups that they thought might be benefiting from this drug, in June of this year, this drug was able to get approved. And so now it's available to patients who have frontline treatment. But the important thing to remember here is that the benefit of this combination is really only in the maintenance phase, so that there was very little gain by giving this with chemotherapy during the chemotherapy phase alone. But when it was considered with the maintenance phase as well, then that's became an effective strategy. The newest drug to kind of fit in this space that was, for which we heard about, we've not seen the data yet, but it should be coming very soon, is this drug Lynparza, or Olaparib, which is a PARP inhibitor. This is a study that was done in a special population, so just patients that had a germline mutation in BRCA. Once those patients were identified, they were given chemotherapy, and then after treatment, they were then given Olaparib as maintenance. So it's very similar to that pazopanib trial that I showed you before, but here this is in a limited group of patients, and they're looking at Olaparib versus placebo. So this is a press release that says Lynparza significantly delays disease progression in phase 3 first-line SOLO-1 trial for ovarian cancer. And down here in the fine print, you can see it's in women who have BRCA mutated advanced ovarian cancer. So this is not for everybody, but looks to be a very important finding for patients that have the germline mutation in BRCA. And so we'll hear more about that soon. Another trial I'm just going to share you just briefly with is the Athena trial, which is also including a different PARP inhibitor called Rucaparib. I should say actually here that there's another trial that's going on in the same space, but not limited to the BRCA population, called the PRIMA trial, which is looking at a different PARP inhibitor called Niraparib. And so we're expecting to hear data with that sometime next year. So that'll be a broader population of patients that will be looking at whether or not this idea of using a PARP inhibitor here is actually beneficial to patients. The third of the PARP inhibitors, Rucaparib, we can see right here, is being done in a trial that just launched about a couple of weeks ago called Athena, which has 4 arms, and you can see the arms right here. And this kind of the other secret sauce in this particular trial is looking at the combination with a drug called nivolumab, which is an immunotherapy drug. So this is looking at the combination of a PARP inhibitor plus immunotherapy. And you can see that the other arms of this trial are essentially there to tease out the benefit, individual arm benefit of these drugs. So lots of exciting stuff in that space. Now, in the recurrence setting, so that's pretty much focused all on the primary setting. But in the recurrence setting, we have these drugs that have been recently approved, also in maintenance. Here you can see with the blue M, and we have 3 different classes of drugs: PARP inhibitors, angiogenesis inhibitors, and immune checkpoint inhibitors, all of which are being looked at in these spaces. And we have data for 2 of these, the PARP and anti-angiogenesis inhibitors, that have been the most exciting thing we've seen. And so we've gone on and looked at this patient population that has a recurrence and started to categorize them on the basis of features that we think will lend themselves to better outcomes when the tumor comes back. And so all of these are starting to become more important. So many of you may know what your BRCA status is, and that's because we've made it a point to identify this very early on in treatment so that we can find a way to give these regimens that seem to have very strong benefit if the tumor comes back. So I'll briefly just mention about bevacizumab, because this is a drug, as I just showed you in the frontline setting, it was gained approval this year. It got approval in 2 settings. So one, it got approval on this basis of this trial here, Aurelia, for platinum-resistant tumors. And on the basis of Ocean's and GOT213, it got approved in the platinum-sensitive space. And so you can see, again, I kind of summarized this all in this one table with these hazard ratios again, but you can see they're all significant for all these different drugs that are here. But right now, bevacizumab has the approval to use in both those platinum-sensitive and resistant settings, and is now available for treatment. And this is given again as primary treatment during chemotherapy and as maintenance. So I think what we're probably most excited about most recently in the last year and a half or so has been this PARP inhibitors. PARP inhibitor drugs are drugs that take advantage of the inability of tumors to repair themselves by having an endogenous defect in that machinery that makes the DNA work. And so when we give a PARP inhibitor, we make it more vulnerable to not being able to repair itself so that the cell can die. So it's kind of a 1-2 punch that you need to have, and each part is really important. So these trials were conducted in patients who were given platinum-based treatments. Here is this chemo 2 and 3 and 4, etc. And then these patients were then, once they responded to treatment, were then given a PARP inhibitor, and that's what given where those purple boxes are with the M's. And 3 of the drugs, as I mentioned before, Niraparib, Olaparib, and Rucaparib, all have now data and all are approved in this setting and are available to women. The drugs Olaparib and Rucaparib are also available for treatment, but all 3 of these drugs are available for the use of it in patients who've had a response to a platinum-based treatment, and they're all FDA approved. Now, the data from these 3 trials, of these 3 drugs in our patients has been remarkable. When we first saw the data from the drug Olaparib in one of the very first trials that was ever published that looked at this drug in the setting. We had never seen these hazard ratios as low as they are, which indicates how strongly significant the effect was. But you can see now that we've evaluated both rucaparib and niraparib, the first of the drugs, niraparib, to be approved in this setting. You can see these hazard ratios are so low and they're so impressive, and they're just absolutely remarkable from their impact on women. And this is just I just pulled one example because I want to make a point about quality adjustment. But this is what these curves look like in the patients. So remember, I showed you those curves before where they were really close to each other, and they look like there weren't very much separation. But these are curves that we see consistently when we talk about maintenance therapy in the recurrent setting for these drugs. And you can see they're substantial. I used to always say to my trainees that if you could put your finger out in front of your face and you could put your thumb in between these survival curves at arm's length, then they were super significant. And this is one of the few examples that we can actually show that. So, I mentioned in the first line setting that toxicity is actually quite important because for example, with that drug pazopanib, there was a lot of toxicity, including liver toxicity that was seen, and fatigue that was seen with these with that drug, and so that really kind of negated the benefit that we saw. So this is a trial, a study that was just recently published that looks at the experience of Olaparib, and this is in a group of patients that were all considered BRCA mutation positive. And you can see there in that population there was a big difference between these two curves, obviously very significant. But they did something else which I thought was really cool. And what they did is they said, hey, listen, we know these drugs do cause more toxicity. Why don't we subtract the toxicity from the efficacy and then see what happens over time and see if these curves are still different? So this is what they came up with. So you can see here at the beginning that this blue line, which is the top line here for the efficacy population, the dotted line is when we've subtracted out the toxicity. And so what you can see is that there is toxicity with these drugs early on in treatment. It looks like that because these lines now start to parallel each other after about it's 3 to 6 months of treatment, that you basically get over that additional side effect. So the side effects are early, but they go away. And you can see the placebo effect is down here. It's very close to what it was like because you would expect placebos not to have toxicity. So when you separate the curve, this blue dotted curve from the red dotted curve, you find over here that there's still a significant difference. And I think we found that this is pretty informative for us to say, listen, even in the face of toxicity, this benefit is really high. And so what it tells us is that we need to do something early on to mitigate the toxicities. And so for those of you who have actually been on PARP inhibitors, a lot of what we do is try to tell you how to take it, how to take the nausea medicine, how to combat fatigue, sleeplessness, and that kind of stuff. And so those are the things that help to increase the quality, and so to make these agents actually more tolerable and work better. So currently, we have a number of pursuits in this field. Obviously, these drugs have shown merit, particularly the PARP inhibitors and the angiogenesis drugs have shown merit by themselves, but we certainly can do better because, as you saw, all those curves seem to go down in a banana kind of fashion. So we're looking at these drugs now in combinations. We're looking at them combined. There's actually one trial that's combining all three of them. And we're looking at other things like vaccines that might be able to leverage the immune response so that if the immune system has memory of the cancer, it will be able to handle anything that comes back up. So I think kind of putting this together to sum up, and we'll take some questions here in a second, is that we still look to improve overall survival. We know that it's very difficult to do that because patients now are living so much longer than they had in the past, and so the effect of any one therapy along the way is hard. It sometimes gets buried, particularly if the patients that are on study get access to the drugs after they come off of the trials. So we still look for that to be our gold standard, though. We know that these drugs may not be cost effective, but as we try to figure out how to improve the efficacy and reduce costs, those ratios are starting to become much more relevant. particularly as the efficacy is measured in years instead of months. And I think as we spend as much time trying to prove efficacy, we are also spending a lot of time to understand the toxicity, particularly financial toxicity, that some patients experience. And so some of that financial toxicity is coming at the expense of treatment that doesn't really work in them at all. And so the way that we handle that is to identify populations of patients where we know the medicines work and not give it to patient populations where the medicines don't work. And so much more work of that is continuing on coming. So I know I covered a lot of stuff. Wanted you to kind of get the big picture about maintenance because it's such an important strategy that I think very soon will be on the discussion for both frontline patients and in recurrence. And because there will be more availability in the frontline setting, it will affect actually what the conversation we have if the tumor comes back. We want to consider those options in recurrence. So maybe we'll have an opportunity to do a follow-up call like this or a follow-up presentation to kind of address some of those emerging concerns as time goes on. So again, I want to thank NOCC and all of you for your participation tonight, and I'll take a few questions.
Dr. Coleman, thank you so much, and I'm so glad that you concluded by saying we'll have further conversation about this. I'll say to our audience, over the next few months, we plan to present more information, either in webinar format or Facebook Live format, on maintenance. So we're hoping to get as much information as we can out to the women who are dealing with this. So I just have a couple of questions that were submitted to me before the webinar. And one is about how long women can stay on maintenance maintenance therapy.
Yeah, so I tried to address that early on. I think that it's the answer is in recurrent disease, obviously, where our endpoint is really to either toxicity, unacceptable toxicity, or the disease doesn't work, or the disease progresses. We have to balance that very carefully because we know there's a high risk for recurrence even in the setting of a terrific response. So there is frequently we'll have to just balance whether or not, if the patient is responding well to the therapy and they start to develop toxicity, it's really about how much we can modify the regimen to continue on. But sometimes we just have to stop, and that's fine. We try to keep it on as long as we can in that setting because we know that far too often the tumor comes back. In the frontline setting, because we don't know which patients are actually cured and which patients aren't, we have put an upper limit on the number of treatment. And so for the most patients, that number is usually around 2 years. And the reason we picked 2 years is that seems to cover where at least the majority of recurrences would have normally happened. So what we like to say is, well, it covers the exposure period. That's the time period that we would, where we would statistically expect a recurrence to happen. So we want to make sure we cover and don't stop therapy too early, but we don't want to keep it ongoing without an endpoint because it could be being administered for no reason at all, and could lead to other toxicities.
And I think the second question that we have here kind of feeds into what you were talking about regarding toxicity, and that is side effects. Are they, exactly what people who are on PARP inhibitors are experiencing? Anything that people can be looking out for?
Yeah, of course, maintenance is right now is more than just PARP because we also have anti-Angiogenesis drugs that are also approved for that. But in the PARP space, our greatest toxicities, the ones that have the most impact on patients, are things like fatigue and low-level nausea. So unlike chemo, where there's vomiting isn't that common. It does happen, but what's worse is kind of that low-level nausea, which is, I don't know, in my opinion, is almost worse because it's kind of persistently there. So we have toyed around with all kinds of different ways to approach that. I actually find that these non-5-HT3 blockers, like the non-Zofran drugs, ondansetron and those types of drugs, seem to work better than the drugs like Zofran. So I try things like Compazine and Tygan and some of these other simpler antihistamines that seem to work better. And you know, you can alter the time of day that patients take the medicine. If patients get it frequently because they're taking the drugs twice a day for like Rucaparib and Olaparib, there's a once a day treatment with Niraparib that they could take at night that potentially could ameliorate some of that toxicity. So, you know, things like rash, we've seen, you know, a bump in liver function studies that are not have not translated into certainly things like liver failure, but just these enzymes are elevated in the bloodstream. We've seen elevations in serum creatinine, again, which don't measure kidney failure or don't implicate kidney failure, but are just a reflection of the on-target effects of the PARP inhibitors. We see things like sleeplessness because these drugs can affect the circadian rhythm of functions of you know, specific body functions. So there's lots of different types of toxicities that can be ameliorated. It just depends on what's showing up.
Thank you. And I think with that, we'll conclude for tonight. But again, remind everybody that we'll continue the conversation. Please feel free to reach out through our ovarian.org site or through our social media channels. Certainly Cancer Connect is a great place to post your questions. And we thank Dr. Coleman for spending this time with us to talk about this really important topic. And I wish you all a very good evening. Thank you.
Thank you, everybody.
She's from